that's okay. Just in the interest of time, thank you all for coming tonight. My name is Elise. I work for the Borough Primary Health Network, and it's my honour in partnership with our aged care team and my colleague here, Julie, that we invite you here to our dinner tonight, all around mastering those difficult conversations and encourage change for dental practitioners and doctors in the room. So that is why the next speaker is here. Her name is Carolyn Bills. She's from the Health Change Associates. Carolyn is the director of the Health Change Associates. She's a dedicated clinical practice change specialist and is a practicing physiotherapist who understands the challenges of frontline service delivery. She believes everyone deserves healthcare that delivers, and that the health change methodology is the perfect vehicle because it simplifies complexity. Her expertise lies in aiding professionals and leaders to embrace a systematic approach to practice, simplifying the tools and processes so that the service providers are well equipped and confident to deliver exceptional care. The health change methodology has a proven track record and is widely used by many Australian public and private health organisations. Caroline has trained thousands of clinicians across Australia since 2010 and worked with world-renowned research teams and organisations. Her passion is fed by clinician feedback, and she loves the challenge of reshaping a big system. The great outdoors is her playground, and multi-day journeys on horse, bike or foot are her perfect escape. So without further ado, I'd like to introduce Caroline.
That sounds lovely. Thanks. Lovely to be here. I love coming to anywhere rural. I do live in Melbourne, and was very excited to get a direct flight, not go through Sydney. So today we're just kind of going to walk through some of the tools that might help you engage your patients and make it more likely they follow your advice. I don't assume that you don't know this, and so I also hope that the day, after evening really, isn't it, will get you thinking, and we've got a few practical activities. So basically we'll spend a little bit of time introducing a couple of the tools from the methodology, and then we will have a break of dessert and a discussion, and I at that point will get you to do a couple of tasks and report back, and then just have a wrap-up session there. So before we get going, what do you estimate is the percentage of your clients that actually follow your advice? What's the percentage?
Less than we think.
And what's the number you think? Guesstimate. 10? 40? And often it depends who you know, the type of cohort you see. So for some, 40, for some, 10. Anybody up at 80? No? Sorry?
Yes, 10%, 40%.
80% of your patients follow your advice? Yes? Excellent.
That over 70. They follow everything.
Excellent. And that's
80% like following it though.
No, the population there is over 70, 80% or 70% in dentistry.
yeah.
It's over
The other
over
option is the 3% is in nursing, 10, 30%.
Yeah. Well, exactly. And look, when I get in front of groups of GPs, and certainly I mainly stand in front of allied health, but GPs often sort of say between 5 to 20% is quite common, and in certain areas, yeah, it will be more. And so my next question is, for the whatever it is, the 90 or the 10% that don't follow your advice, how equipped do you actually feel to influence them and work out what's going on? Low? Put up your hand, and I want hands like this. Your options are going to be low, medium, high. All right, it's only 3. So it's early in the evening, it's fine. Who feels highly confident that they kind of at least know what they should be trying to do with the people who aren't following their advice? Yep, okay. And medium? Who's mediumly confident and who's low in confidence? Yeah, And it would be the normal kind of bell curve that we have in a population of health professionals. So often when you went to university or did even your postgrad, we were very well versed in getting information and learning about clinical pathways and clinical disease. And so everybody will be very familiar with the clinical condition pathway of assessment, the framework, diagnosis, then give recommendations. However, often for many people, and certainly this was the case for me, what I often found when I went through my day's list is that there were those really tricky patients that I just went, oh, this is not working, you know. And so what we found we needed was a pathway to navigate the person, because as we know, it's all very well to have all of this health information and knowledge and expertise at diagnosis and being able to treat and recommend the treatment, but in some cases you can have the world's great expert who would have worse patient outcomes than the new grad who had a different skill set. The knowledge is useless unless you can make it connect to the person in front of you. And managing people is really the hardest job that we all do. So that's where the gap was kind of in the market, and basically what Health Change Associates, we're a bunch of health professionals, multidisciplinary team. What we actually kind of did was go back to the literature and said, well, what we need to do is we need better skills to be able to more quickly and easily navigate people. And so what, after an awful lot of work, and the good news is we've gone back to the literature and done all of that, this pathway is basically the result of and is concordant with over 49 of the psychological behaviour change theories, concepts, models, all of those sorts of things. And what we've done is just put it into a fairly simple flowchart. Now, but it is evidence informed. We didn't actually just make it up. So that's the chart here. I might actually change and go over here. And you can see that this flowchart really is made up of basically three main areas. That dotted line is actually called the decision line. And that's the point in a conversation with a client that you kind of realise, oh, I think they're actually with me and that they're ready and willing enough to actually go a bit further and talk about what they might do next week differently. And all of you will have your professional intuition and kind of pick up those verbal and non-verbal cues as to whether the client's listening and engaged or not. And above that line, you've got the processes that have to happen in the person's head in order for them to reach that line. And you can see there all about health literacy, knowledge and understanding, about motivation, expectations and decisions. And this is the order of needs that have to be followed, that you can't just go and jump straight to, go away and do this, take this medication. If the person does, these processes will be happening in their head, with or without your help. So what it acknowledges is patients have what we call an above the line process that actually develops readiness and motivation, and then even if they are motivated, they often need help with planning and problem solving to make it actually occur. And then they'll leave your consult and either adhere to the recommendation. Over time, we want people to develop skills when you're dealing with chronic disease and illnesses that don't go away. People need to actually learn how to self-regulate and adjust what they do as circumstances change. So does that kind of resonate with you? And most clinicians kind of look at it and go, oh yeah, I can see that happens and it makes sense. Well, the advantage of knowing that is that what this methodology does, it operationalises person-centred care. And many of you will be familiar with the phrase, meet the person where they're at. Well, what now you've got is a much better concrete definition of where at is. Because if they're not taking action, it means they're stuck somewhere and they're not flowing through that pathway. And the good news is that often people don't necessarily always need the help of a health professional to navigate this pathway. And that's why the traditional model of care works. If you actually say, well, this is the problem, I'd like you to do this, and in fact, if you're lucky enough to have a cohort of people that are listening to your every word and highly respect your opinion, a lot of the time they will sort all this out and go and do it. So that works some of the time, but it doesn't work all the time. And it's those 80, 90 or 60% of people that it doesn't, that we've got to actually see where are they stuck and do we have the skills to see if we can shift them a bit. Of course, the assumption is never that you're going to fix everybody and get everybody through the pathway. I just want to make that clear. And what it reminds clinicians is that you've got to build importance and knowledge first and then confidence. So, any questions about that? Does that kind of resonate, make sense? Yeah, okay. So, often the way care is delivered is what I call polite traditional care, which is we're so good at assessing people and telling them what to do that we normally think of the order of our conversation is that we need to do an assessment, and I'm not disagreeing, and then we need to actually deliver the intervention, and then kind of often along the way we kind of wrap the person in there. And as I said, that can work. But what the methodology does is really actually turn things on its head a bit and actually say, look, intervention is not necessarily only taking medications or going to see another health professional, doing exercises or whatever it is that you want them to do. What we highlight is that our job as clinicians is to actually help people navigate the above the line processes, and that doing that when we're providing information, engaging them, developing the relationship, they are actually interventions. Your conversation is an intervention, but it may not sound the same, and it's not the same as being able to document the actual goal of, well, this is what they did or this is what I prescribed, if you were just talking about something. But the methodology really highlights that that's a critical element, that for some people you need to spend the time doing it, because often if you think about those people that aren't following your advice, where are most of them stuck? I mean, and they'll be stuck everywhere, but...
With motivation and expectations.
Yeah, above the line. And that's often because our conversation, naturally we are so well trained, here's the problem, this is what I want you to do, and then, yes, and I'm very well aware for GPs with really time-limited consultations with massive amounts of assessment and risk assessment and that need to be done, GPs often very rarely have time for an in-depth below-the-line conversation. However, what's critical is that with just often a little bit of nuanced swapping of language, you can often still have an above-the-line conversation very quickly and succinctly, and then getting people to the line. Really, most of your work's done then. This is the hard bit. So the methodology has a whole set of tools. It is a training program that usually, at least takes a couple of days. So clearly in this evening's talk, we're not going to unpack all of that. But all I want to highlight is that we kind of go, okay, well, if this is what people need to take action, because that's the science of psychology and behaviour change, and if that's the order they need it in, and we know they're going to get stuck in that pathway at all sorts of different times, they're going to move up and down, that's a given, then clinicians need to have the skills of actually understanding behaviourally what is it that you do in a consult that means you're being person-centred. And what we've done is just label the principles that you need to follow in your conversation very simply, because that was exactly what the feedback from clinicians said, don't talk about all those theories, just help me understand what I need to do and how to say it in the consult to guide my conversation. And behind those principles sit some skills, and we've just labelled 7 of the minimum skill set. And if you deal in palliative care, if you deal in substance abuse, addiction, really tough areas, people with numerous complex medical problems, you need often a lot of extra skills as well. And there are lots of great training out there that'll give you those skills, which is fantastic. But what clinicians are often saying is, but which skill do I need when to be most time efficient? And that's why what we've also done, which is kind of unique in this methodology, is we give you what we call the consultation or decision framework that matches and helps you go, okay, well, if I'm trying to facilitate through there, why don't I have this conversation first, see what happens there, and then I'll take it from there? Because you can't script it, but at least you've got an order that you know that you're picking up the significant belief and knowledge barriers early as possible. There is a simple way to document that conversation that really is in plain language and clear for the patient and the clinician. It complements your records, it's not replacing them. So that's kind of what's in it. But all I'm going to highlight today is using the behaviour change pathway to help you actually craft a conversation that might happen with Mrs. X. So we've got Mrs. X's some data of, this is her clinical picture at the moment. She's got COPD, she's been in hospital, she's got some triggers from environment. Certainly the medications are working a bit, and she has low physical activity levels. So if you know that about Mrs. X, does that information tell you anything? Do you know where she is on the pathway? Yes, no, maybe.
She's right up the top because she obviously doesn't understand what's happening.
And tell me more about that, Charles.
Well, she's still smoking.
Right.
And she's only 38. She's had admission to hospital 3 months.
It actually doesn't say she's smoking there. It was...
You can guess she is.
Oh, okay.
Really
Okay.
Cough for 3 years.
Yeah. So do we just tell her again to stop smoking?
Well, I think that probably...
How's that going for you?
That probably won't... Well, that's a start. What are you going to do about it comes into the... What's her trick? What's she going to do about it? Because we can't fix it. She's got to want it fixed.
Correct. So what happens... Has anyone been in a social situation where you've got a very good friend and they either want you to read some book that they're so passionate about, and really you've got no interest, and every time you go and talk to them they harp on about this book? What do you end up doing? Okay. People pleaser.
Shut them up.
People pleaser, that's, they're lucky.
It's not my kind of book, thanks, but no thanks.
Okay, you then definitely say over it. What else strategies do people do? You pretend, you avoid, you reduce how much you see them, and sometimes does it make you really angry? And it may even impact on your friendship if somebody's really in your face. So that's what we've got to keep in mind of when we just tell people. So the medical information, at least very clearly, we know what we wanted to do, but it doesn't tell us yet where she is on the pathway. She could be anywhere. So What do you want Mrs. X to do? What are some of the things clinically that you'd like her to do?
She didn't come for the last 3 months.
No.
She didn't, so she needs to come for.
Sure, let's assume she's going to come. What do you want her, when you get an opportunity to speak with her, what are the clinical treatment activities that you want Mrs. X to do? On what?
Her medication.
Yes, you'd like her to take her medications. Yep, great. What else do you want her to do?
Ask her about her expectations. What is her view in her disease? What does she expect? What she can be doing?
Yep,
How far she can manage exercise and weight?
that's absolutely fantastic, and that's part of the process. But at the moment, just tell me the other things that you want her to do. Are you all happy if she just goes and takes her medication and that would be the best thing for her? What are your clinical guidelines for COPD? So what else do you want her to do?
Avoid one to three.
Sorry? So you want her to increase her physical activity? Yep. What else do you want her to do?
Avoid the triggers.
Avoid the triggers? Absolutely. Terrific. Great.
Vaccination.
Yes, vaccination.
Cold,
Excellent.
cold, pneumonia.
That's it. Good. So, usually at least you've added a few more, but she needs to actually make sure that she actually understands which medications for which, that she takes them as prescribed, that she probably paces her physical activity. Is that that's a familiar concept, isn't it? Yep. That she then builds her physical capacity, avoids the triggers, and knows when to worry about her shortness of breath or not. Okay? Everybody kind of comfortable that they would be a list of things if she actually started to do one, and Charles would like her to stop smoking. And if she does smoke, yes, that would absolutely be on there. Would everybody be happy if she actually started doing those things? Yep, great. Yeah. Belly tip, you're always just one step, a jump ahead.
I'll keep getting
No. So this is what we want her to do. And what the trouble is, and that often we all have, when we see the clinical picture, we already have our list, correct? That's how we're trained, and that's good. But how we've learnt that list is often from the way we're taught, which is from clinical guidelines that tell clinicians what to do. We learn these are the assessments, these are the investigations, these are the types of things we need to tell them. You know, do you think that that's how your information is generally ordered in your head? Yeah, and it's common. It may not be, and that's okay.
No, what I mean is that we have this information. But
Yes.
if another patient input tick box, are you able to do that? I will do this, I will not do this. I can do that, I cannot do this.
Yes,
So it is parallel to what the patient can do.
absolutely. That's right. So the way you communicate with Mrs. X can significantly influence whether she puts her head in the sand or just smiles at you politely and nods and doesn't do it, or whether she actually sort of says, forget it, I'm not doing it. And what we know, the strategies in a consultation, if you just tell her to do all of those things without much explanation and without much other nuance, that's not going to go well, is it? And if you tell her to do all of them, that's definitely not going to go well because she'll be overwhelmed. And if she doesn't know anything, and those expectations, as you highlighted, absolutely critical to do quite early on so that she has reasonable expectations of how does COPD, what happens if you do nothing, or what is the natural course of this disease. So that sort of broad information is critical. But if you also get really frustrated and say, but if you don't stop smoking, you'll end up in a box. We know that scare tactics don't work, particularly without being given hope and support. So these are what we know have been proven to be ineffective, yet, you know, I can certainly put up my hand. Have I been guilty of using those strategies? Absolutely. And particularly the more time pressured and the less time we have, our default often will go back to those strategies. Do people relate to that? Yeah, and we're not perfect, but we just want to be aware of that. And what we would suggest is that clinicians need to be taught other strategies to actually align their conversation with this pathway. And of course, the first thing that you need to do with anyone, as you well know, is build some trust and get that relationship started. And that job never stops. You know, that just because I put it number one doesn't mean that, oh, tick, done that. You know, that obviously is absolutely ongoing and pivotal. Do you know the number one predictor of adherence to advice from health professionals? It's the strength of the therapeutic alliance. So over and above anything of what you say, which is why you can have the new grad who for some reason either really relates well to people, gets better outcomes than the senior clinician sometimes because of rapport. So that's certainly, you know, I know you all know that, so that's not where I'm going to add value to you. But we then need to try and actually give some information, and the real kicker is that all you need is a big picture view, because they don't need to know everything, and you have to drip feed it and layer information. And all the palliative care team here will have been doing this intuitively for years, okay? And all we've done is kind of just put it into a structure and given a few tools to help other people get the idea of doing this. And when you actually give your information really well and map that big picture, what's interesting is that more people tend to be on board with you. It makes sense to them, and so you have less resistance. And then your job, they're much closer to the decision line, your job is much easier and a little bit faster. And then the third task is certainly, once they know what to do, make sure they know how to do it. And so if you look, what we've provided you with is this little card here, right? You don't need to really look at it now. But basically what I want to highlight is that this is a way to help you layer and decide what sort of information's critical above the line that's likely to influence someone's motivation. Because often the way we know our information, we emphasise things that patients don't necessarily think are important. Many of you will have already sorted this out and worked this out intuitively yourself. But what we've done is help you with a bit of a system, and on the back of the card there's more detail of what types of things of the information that you should pull out from the guidelines. So this is a way to actually translate clinical guidelines into areas of action that people need to do to get the outcome. So, the first task, Mrs. X comes in, and this is, you've got a little bit of extra information. You know that she feels the shortness of breath's worsening, that she's having difficulty climbing the stairs. She shares that last time when she was in hospital, she felt like she was going to die. And when talking about her medications, she just kind of says, you know, they don't seem to be doing much. So now that you've got that piece of information, how do you think she's feeling generally about things?
Crap.
Yep. Give me some other words as well as crap. But that's a great start, and you're right. But she's not going to be jumping in going, oh, yippee, tell me what to, you know. Hopeless, out of control. Yep, absolutely.
Anxious, frustrated,
And
overwhelmed.
anxious. certainly like she felt she was, yeah, nothing's really working. I don't know where I am, and I was scared witless that I'm really about to die. Okay, so given that you almost, and a lot of the time you've already kind of got these nuanced, when you know people, you often can very quickly say, how do I think they're actually, how do they feel they're going? And if you come up with any of those emotional words, particularly like loss of control, hopeless, terrified, you know you should be up here with them, because often their capacity to listen and do anything might be less anyway, because those emotions stop you thinking well and clearly. So just have a moment, and what we can do, I know, see how you, although gosh, most of you have actually done a fairly good job on your meals. What you've got here in front on the table, that you've got some of the sheets of paper, and there are some pens. All I want you to do is have a go at writing a few things, and all you're going to do is write a couple of notes for yourself, one words, you know, and then when you have dessert, you're going to just share some of your answers together and share the phrasing. A lot of people develop rapport. They think to do that, the best thing is to ask about the kids or the football team or those things. And they are certainly valid ways to do it. But often, by just actually acknowledging someone's situation, you can do it very quickly with just a sentence or two, and people kind of go, oh, wow, you get it. And they really relax. So if you can anticipate how they're feeling and put them either at ease, think about what you might say that might put Mrs. X at ease, just one sentence, and really write it as what would you say to her. I'm not interested in an intellectual response. It's just what do you say when she first walks in the door.
When she walks in the door?
Yeah, just you're either, you know this stuff very early on. What can you say to put her at ease? Just write down one sentence. Doesn't matter, and we're not going to share it now. We'll share some of this stuff in the debrief. And there's no, obviously I hope you all realise there's no right answer here. Okay, and everybody will kind of have a different take. However, I will give you a hint and say, for God's sake, Mrs. X, do stop smoking, is possibly not your best opener.
And surely after that you get out the 42.
Yeah, that's it. Well, it is an established method of management, isn't it? Okay. So your next task, so what I'm doing is going through your 3 tasks in the order that they should kind of occur. And so that first task in that first 5 or 10 minutes, you want to be focused on kind of at least settling down or, you know, relating to the client in some way. Your second task is actually, as all of you highlighted, is kind of start here and work out, gee, I wonder which bits she does know and what she doesn't. Now, given she said the medications don't do much, what you want to do is ask some open but very targeted questions, because fundamentally people, in order to get to the decision line, need 4 pieces of information. What have I got? Why is it a problem for me? What helps? And either why would I bother or why does it work? And that's why we've actually kind of, and if you want to put that language, what's the problem, on writing on that card, that can sometimes really help you have that conversation, that simple what and why. So, What's the question? Because you want to know fundamentally, can she actually control and does she understand what makes her more short of breath or less? Because clearly that's what she wants. The good thing about COPD is people know what the problem is. They know they can't breathe very well. But then they don't necessarily understand why they can't breathe very well. Always. So if you wanted to find out, gee, I wonder how much depth of information she knows, what's one question that you would ask her that would, her answer will kind of tell you and give you a gauge on what she actually knows.
Something like, do you avoid activities you used to do because of your breathlessness?
That is it's a very useful question to gauge what's happening, but it doesn't help you understand whether she knows what influences her shortness of breath. So I'm looking for a different question, but don't.
What makes it better and what makes it worse?
Well, they are assessment questions. It doesn't tell you whether she understands.
What do you do when you're breathless?
Yeah? So all I want you to do is pick one of your questions, write it down, and we'll debrief and toss around. They're all valid questions, but you try and want to think, what does she understand about it? If your brains aren't hurting, you're not learning. That's why I'm challenging you just a little. Okay. Now, this one is a little bit more challenging. But this is your job. Your job is to be able to explain COPD briefly and succinctly and to help people understand what works to treat, to manage it. So I also do want you to have a bit of a go at just think about what you normally say, write down a few dot points of what you might include. Because I don't need you to write the whole spiel, but if you've I just want you to think about what you normally say. And this is one of the most challenging tasks that we as health professionals have, to try and explain often very complex conditions or circumstances simply as possible. And the more you get practice explaining this what and the why, briefly and succinctly, the quicker you will often find you'll connect with people, because guess what? That's what they want to know. They want to know, what have I got, and and what works. Not an easy task. So what I'm introducing now is the tool that we call a menu of options, that really translates those clinical guidelines into quite simple chunked areas for people. And this relates to this tool that I've given you here, which is the full menu of options. And I'll just highlight, this is not to go in front of people. You would just totally overwhelmed. Yeah, exactly. Here you are. But what I want you to highlight and just realise is that it relates to the pathway, because what have they got and what works to treat it kind of sits here. That's the health literacy bit of a big picture view, not a lot of detail, just a big picture view, and the decision line kind of sits underneath those purple boxes conceptually. And you'll notice if you look at the health condition side of it, the language is different to the language I've got up there. But if you just look at the health condition side first, can anyone tell me, so in the blue box it says manage health condition, that's all I want you on that side. Can anyone tell me the medical condition that those purple boxes don't apply to? Can you think of a condition where those purple boxes don't apply? Is that a no?
It's a tricky question, isn't it?
I'd just like it to be a resounding no. I can't. Yeah, and is everybody seeing that? You can substitute, and the beauty is if they've got 8 conditions, no, but there's still only 6 areas to manage. So always think of it, the purple box is what do people need to do over time. The language is flipped from I want you to do this to if you've got this, people need to get busy, and the people who do take action in all of these over time get the best results. That's the science. But people don't understand that because it's not often explained in that way. Now, many of you already do fantastic explanations, so I'm not discrediting what you currently do. But what do you think the benefit might be of giving them a kind of a brief explanation? And you'll see that what I've done here is I've kind of changed the language a bit to be a little bit more specific to the recommendations around COPD. So what I've put up there is the patient's concern, because we know that actually what she wants is I really want less breathlessness. And you could quite easily say, well, Mrs. X, if you want less breathlessness, can I just explain to you? And people need to know which meds to take and whether you can mess with them or not. They need to know whether to worry about their shortness of breath or not. And that takes a little bit of trial and error. But you also need to know there are some things that you may not be able to control, and go looking for making sure that you stay well and that your body's not overloaded. And ironically, the fitter you are, the less shortness of breath you have. Now, you would always follow that by, I know that won't make sense right now, and don't worry, but let's just park that. But actually, physical activity is often as good as medication at helping you manage your shortness of breath in the long term. We know that, and my language here is very deliberate, we know that even reducing smoking, and gold standard of getting rid of it altogether, but even having periods of time where you don't smoke will really help your body cope. And you've got an illness that your lung capacity was there, is now here. You've only got a certain amount of oxygen, so you've got to make really good decisions about how you use that so you don't run out and kind of fall off the cliff. Did that make sense to you? Do you reckon it'd make sense to a patient? And it took me, 3 minutes maybe to say all that?
But they didn't interject.
Because I asked permission to tell them something. Yeah. And I didn't say, how are you? That would be, in my book, one of the worst opening lines for some types of patients. Very dangerous, that question. So what we choose to say and when is critical, and absolutely, there are some patients that you'll never get that time, and we can't control for that. But what I'm highlighting is that I'll put it to you. How often do you think that's routine practice of care, that explanation is routinely given? And I'm not saying you need to only give it once. You would need to give this again and again because it's the same message. Is that routine care? Yeah?
Might be gold standard, but it's probably not routine.
Yeah. Oh, look, all I would be saying is that maybe. But the more it is, that's fantastic. And the difference of it is a lot of the time all clinicians talk about these issues, but often they talk about them one at a time. And that actually is different. That's not what I'm saying. What I'm saying is the gold standard is that you need to have this big picture where you lay each of these out. Now, you don't always have to have all of them. If you had a client with, cognitive difficulty, you may simplify it, but you certainly wouldn't want any more than those areas. But in my experience, it's not usual practice for clinicians to be able to do and explain COPD exactly using similar words to what I did. Yeah.
In my line of practice, I'm a mental health social worker. I unfortunately do get a lot of people that come in and say that they didn't feel heard by their GPs, or it all happened so fast that they left there very anxious and scared. And I think sometimes, although GPs feel like it might be coming across like that, it's not being taken like that, because like you said, they're coming in anxious, overwhelmed, frustrated, their head's kind of in a whirlwind. It may take a few sessions for them to feel heard and get that kind of across. So
Yeah.
That's definitely some feedback I get from people, that first time of hearing that, they don't hear anything else after you have COPD.
Yeah, absolutely. And all there is, obviously, the critical thing I want you to take from this is not a prescription. This is a guide to a conversation that in the end you adapt, right? And you'll notice that the language can be flexible, you can change it around, it needs to be adapted, as I said. But when you at least have a go at explaining something quite simply, without much detail, and then immediately as soon as you've got 3 or 4 things out to be saying, and don't worry, we're not doing all of that today. And pause the conversation, and then it's about, in order to actually test what has the patient heard, that you can then throw it over back to your patient to say, how does that fit with what you know, you believe, and then you can really start that shared decision making and find out from the client what's happened. So the beauty of this also is that you actually don't need to know much about them. As long as you've got a diagnosis of COPD, I don't need to know any detail of what they're doing with their activity or their stress or how terrified they are. I can just talk really briefly and broadly and say, these are the kind of the things of how this goes, and the people who get the best result take actions in these areas over time. And that's what we're here to help you do. And imagine if all of the allied health care team used similar language. Do you think your messages might land a little bit more consistently? It was so great to hear the work that you guys have been doing on that cross-pollination and the more we all talk. So this menu of options technique is kind of often a way that sometimes you can save some time and explain complex things a little bit simpler with not a lot of detail, because the next step obviously is to then prioritise. And probably, the first thing is, yes, let's start here. And then you get them going on that. So that's obviously up to your clinical decision making. So that's that concept. And as you're then talking to the client, you're using what we call our RIC radar. RIC stands for Readiness, Importance, Confidence and Knowledge. And basically, they are the 4 critical elements that decide whether actually someone is successful doing something or not. Now, we put it in that order because it says a nice word, but really it should be cur. All right? And there isn't an order that you do it. So I'm absolutely assuming you're all quite comfortable with those as concepts. Importance, motivation, yes? Yeah? Who already asks importance or confidence questions in routinely? Yep, some of you, yeah. Terrific, great. And Rick is one of our foundation principles that as clinicians, all of our knowledge is useless unless we start to actually interpret readiness, importance, confidence and knowledge because that's what determines the speed of the movement through the pathway. And your clinical intuition about whether they're with you or not is what we label Rick radar. You know, you've just turned on your Rick radar. And so start to, when you next go see your list, really just start to interpret what they're saying in terms of what does that mean about how motivated they are? What does that mean about what they understand? Or so the key word of comment for Mrs. X of, I felt like I was going to die. Okay, well that's clearly, a big emotional reaction that needs to be managed and addressed. So you'd be thinking about, okay, maybe I need to talk to her about actually, and perhaps as can happen, how many COPD people present to ED thinking they're going to die but actually are not in any distress? Hundreds. So it begs the question, who's having the conversation to help the client understand when to worry or how to have a little bit more control or assessment of what's happening for them so that they can calm themselves down in an ideal situation or know what to do to manage that fear. So you can either ask more direct importance, confidence and readiness questions if you want. Has people done motivational interviewing training? Yeah, fantastic. And so you'll see where all of the concepts here absolutely dovetail beautifully with motivational interviewing. For a while there was a lot of scaling questions. Does anyone still use scaling? So how important is this on a scale of 1 to 10? Okay, and scaling questions can work, but as a general rule, we absolutely say, just talk to people like poor people, and a nuanced question without it being formally scaled. Not everybody relates to the numbers. And what happens, particularly when you ask importance, they know you think it's important, so they're going to give you the answer you want to hear. So you get artificially inflated. They're not really telling you. So you want to just be mindful of that. And the other technique that will help you do shared decision making is what we call Rick-focused decisional balance technique, which is a way to weigh up the pros and cons, which I'm sure perhaps many of you may have been experimenting with. So we're nearly there and dessert will happen. How are you going? You all right? Okay. Luckily I didn't hear that.
You said nice food.
So, the rules for you of when you're either, saying, look, Mrs. X, to get better breathlessness, and you can actually still make really strong recommendations clinically to say you're going to get the best bang for your buck if you do here. So this methodology is not, sometimes people worry that person-centred care is all about, what would you like to do? And that's not what person-centred care is. It is you balancing your duty of care and making clear recommendations of what will benefit the client, but making sure you explain the why and check their understanding. That's sometimes the bit that we think that we've said it, but sometimes it's grey for the client. And the rule is, if importance is low, so if you think Go and do this. Is it tomorrow? Is tomorrow a holiday here? No, it isn't. It's a holiday in Victoria, of course. Look through your list and actually go, okay, this is the main clinical problem. Where on the thing that I know would give this patient the best clinical benefit, think, what's their RIC level of importance of doing that? And if you think, low, you go, great, you've established they're above the line. So what do you want to not do? If they're sitting above here and you want to meet them where they're at, what do you want to not do? Yes. So you don't want to say, just do this. It's really good. Okay? You need to ask more questions, probe, and either, in fact, the fastest, most time-efficient solution is to just actually go, gee, Mrs. X, you seem a bit, half-hearted on whether actually taking your medications is going to really improve your breathlessness. So if I ask you a few questions around that, I can help you make a decision whether actually you really want to have a go at taking them consistently or not. Would that be useful? And then you go straight into that, and when you're talking about the consequences of not taking the medications consistently, that's your cue to actually provide information, often in a way that stops you telling them what to do, but helps them understand. So often it has a lot more power than when we just tell them. So it's a really useful, but it's not how we're trained. We're trained to tell, so it's our default.
I was saying that's motivation.
Yeah, absolutely, but it's often hard to integrate into your practice, and it's really hard if you've got 15 minutes with a whole lot of other tasks. It's really difficult. The other rule is that if confidence is low, then just make things simpler, and I'm sure you all know that. But really, try and break it down, and I even just ask the question, what would make this easier? What would make this doable for you? What would it need to look like? Your patients often have a lot more strengths and resources than sometimes we think. So it's always a good, thing to just sit back and, as a rule, see if they can come up with a solution. But then if they can't, by all means, help them out. So all I want you to do now, just before we nearly break, is see if you can phrase an importance question. Now, I'll give you a bit of a hint of how they are often phrased. So it might be, so how important do you feel it is, Mrs. X, to actually prevent yourself getting a cold? Right? That's an example of an importance question. And you'll notice that it's not, do you think it's important? It's open, so hint, start with how, and then literally see if you can do it without using the word importance. Pick one of these. That's for you, Charles.
Thank you.
Yeah.
I take direction well.
Pick any of them, because remember, the beauty of the menu of options is you're happy if they actually take action in any of those. So that's a good thing. So just see if you can phrase one importance question. Okay, so troubleshooting, kind of putting what I've outlined together. If our job is to help move people from here to here as fast as possible, understanding that some people will never get across the line on some issues. Whenever you've got kind of a difficult client, Just normally now rephrase it in your mind and go, they're just above the decision line. They're just not with me. And I was probably all down below the line by yourself. And so you want to be where the client is and have a different conversation. When there's chronic and complex issues, this becomes even more critical, because how often is trying to work out, you've got so many movable bits that everyone's really struggling because it is complex. And I can hear to say the methodology doesn't solve, and it's not, you know, rainbows and unicorns. It doesn't solve complex issues. It just gives you a little bit more of a structure to more methodically go through to hopefully get traction. And the whole idea is outline the big picture, focus on an area, get them going on that, come back here, and you basically keep flipping the conversation. Sometimes big picture, delve in. And when you're feeling stuck with a client, are they above or below? Always think, what do I want them to do? Are they above or below the line? Try and unpack where you think is it their knowledge, or what's demotivating them? Is it a fundamental belief? Nobody in my culture lives beyond 40. So that's a massive, and if that's their lived experience, why on earth would they be optimistic? So that's what you've got to actually talk about, that, and to be saying, and that's where the advantage of using people with lived experience, because often your client's beliefs will be shifted by other people, not necessarily always you. However, you being doctors hold enormous respect and power. And what you say can make a massive difference to the whole team and to how your client is moving through. So, you know, you've actually got a lot weighing on your shoulders. And obviously, this concept applies to end-of-life care, or you can put anything up there. Now, I've just kind of put these together. I'm not suggesting that this is, you know, how it is, but you can imagine that rather than saying, oh, let's refer you to the palliative team, because the word palliative just sends everyone over the cliff, understandably, you might say, you know, let's map out the future a bit for your health. Let's have a bit of a brainstorming for the future. Okay, maybe we need to look at various things, or you need to know what's happening. You know, but, you know, considering an advanced care directive or care planning. So thank you. I've now learnt a lot more about the language, and it's all about the language. But if you at least just put a couple of chunks down, you will then open up a really nice conversation, hopefully. And the good news is, a bumbling attempt at doing this is much better than not. So, sorry?
They'll forgive you.
Yes, our patients are so forgiving of us. Now, finally, we do have one kind of, this is the piece of paper, an example of what we call the personal self-management plan. That what you can see is on this side of the form, oh, there's those purple boxes. That doesn't change. That is your behavioural areas till they die. And all that changes is what they're doing this week, next week. That will change. And often what will change is the priority will change for people. But this gives you a really nice way that you can have those there visually for the client and then talk about them. And it reminds you to talk about them generally, make sure they kind of understand it to a certain degree. And then it reminds you the next task is, can we prioritise something? And this can be done any way you like. You can just have one and the others are blank. Doesn't matter. And then it reminds you, oh yeah, I better check in with the client as to how they feel. But if the client's prioritised it, often they're happy. And this works with people's, you get less resistance because you're subtly manipulating them for the purposes of good. And then you're going for the action time frame. And I'm interested in your comments. If you picked that up and just read that and somebody else you're filling in for someone, would you know pretty quickly where to start a conversation with that client? Yeah. Certainly for me, much better than rifling through a whole lot of notes that doesn't actually tell you anything of what the patient's doing. Great. So, if you're feeling like you've got messy head, you and your clients, try and chunk information. Look at the content from the health literacy card to prioritise it, and use RIC to really engage in much more of a shared, even conversation, and acknowledge that sometimes people aren't motivated, and to see if you can influence it. Brilliant. Thank you, everybody. We'll have, now what I'm going to do is you've got this table. There are two highlighters, sorry, these are the only ones I had, so you can fight over them as to who takes them home. They're just little for anybody. And over dessert, certainly have a break so that clear your head, but either I'd like the back table to consider and come back, nominate a spokesperson, and when we come back, I want you to just either comment on how you think any of what we've discussed tonight would apply in palliative care cases, of just how would you apply that, and just make a comment. The middle table, I'd like you to share can I borrow this? Just I've forgotten what I've asked you. I'd like you to tell us about what's your opening phrasing to put Mrs. X at ease, and this table can tell me the RIC question. Give me an example of your RIC question. Fabulous. Thank you very much for your time. Sorry to interrupt the conversation, but we'll just have a bit of a debrief on that, share some of the thoughts and ideas, and then let you get back to your busy lives. So, where are we going? Maybe this doesn't work. Okay, so the table in the middle, I think, had what are we going to say? So just to refresh your memory, Mrs. X has walked in. You know that she said, oh, last time I was in hospital, I felt like I was dying. She doesn't think her medications are doing much. So what can we say that just, might just make her just feel a little bit more, okay. Go for it, guys.
Our approach was we were kind of looking for two key things needed to be done, like acknowledging her situation with empathy and then providing her the opportunity to validate what we suspected was going on. So two of the questions that response we came up with was firstly, I'm terribly sorry to hear about what happened. I imagine you're feeling worried, so acknowledging what's happened and then allowing her the opportunity to validate that. And then your response, if you want to read yours out. I'm sorry to hear about what's happened. This disease can affect a lot of people's lives differently. How is it affecting yours lately?
Yeah, so that's a really nice question, a nice open question, but going for the impact, which is going to bring up the motivators.
It's also saying how much knowledge she actually has.
Correct. Yep, exactly. So really, you can see how much you can get out of a statement than a really good open but targeted question. really trying to dig around up here quickly to then work out, how quickly can I move and, where do I go next? Does anyone else have any other, things that they'd like to share? Because there's a million different things you could say. Does anyone want to toss around any other ideas?
I think, when does this happen for you? To see whether or not she understands when that breathlessness is happening. So that's me trying to seek her understanding of it.
Yep. So that's an excellent knowledge question. Will that put her at ease?
Oh, my earlier one was more validation, letting her know, so I understand this must be really challenging for you.
Yeah, good.
I'm here to work with you to help you.
Yes. So that's an excellent thing of, that's hard, that's what I'm here for, I hope we can work together, that sort of thing. Fantastic. And then how you seamlessly then move from that kind of, okay, hopefully you did all the technical language of what it was that nice word said. And then you're kind of moving on to, I wonder what's happening with that breathlessness. So you might ask a few other, again, open, targeted questions. Terrific. Does anyone want to add anything? Anything on, obviously building trust is pivotal and it doesn't stop. And so whenever you suspect that the relationship's not working for some reason, you need to use the principle that we name, call it as you see it, with tact, which really is about having those difficult conversations to either bring up and say, see that thing over there? I think it's an elephant. I think maybe we need to talk about it. But you need to do it gently. It's not being confrontational. Any other comments or anything about that? Yeah.
I will start. I will say, Miss X, I can see you are upset. It was some hard time lately. How can I make it easy for you?
Lovely.
Because I was thinking different in the first time when she came. I said, you again.
Excellent. Yeah. Great.
Just being different.
Okay. Terrific. So the main thing I really want to highlight that certainly I come across a lot, I mean, I have the privilege of being in rooms with a whole lot of different health professionals, often allied health. And the good thing about being an allied health professional is often we do get a lot more time than doctors do. But people think that building trust is just talking about other things. You can build trust with how you do your job. And so it doesn't necessarily have to take up extra time. And there's no problem with those other, light conversations are, great. But if you're really time poor, try and do it as you're doing your job. Will make your life a little easier.
I think people underestimate the power of validation.
Yes. Yep, absolutely. And so reflecting. And so often, and that's where you can, that's why we create these as practical tools, is that sometimes you can kind of put this down and go, maybe imagine that it was Bill who I'm just beside myself. We're going round in circles and he's all over the shot, I'm all over the shot, don't know what we're doing. So I might come in and say, Bill, do you mind if we take a different approach today? And he, of course, nicely says, yes, of course, Caroline. And I go, look, I just want to kind of zoom out and get the big picture here. And so I need to make sure that you know what you've got and why it's kind of how it's impacting on you and why it's important to you. And then I need to know that you know what helps, because there are things that help, and either why you'd bother doing those things, because often in health, nothing that we should do is particularly fun to do, but why you'd bother or why it works. So, I don't know, over to you, Bill. And sometimes that sort of absolute, tell me about this, people, you might be surprised at what comes out of their mouth, and it could end up being a really productive conversation. there's your challenge. Go try. You know, it's just one way of doing it, and there's lots of different ways. So, you know, all I've put up here is just some other, you know, reflections. Don't underestimate the power of summarising and then telling people what you're about to do and then checking in. So this is the whole thing of, yeah, and this is where if you have this in front of you, you can kind of go, I'm really wondering whether I've done a good job of you understand the big picture of what works. How am I going on that? Or I'm really wondering what's driving you. A lot of the stuff I want you to do is pretty awful. You know, what's going to light that spark to get you going? Because we know that I can't do it for you. So all of that as your conversation, as opposed to, do you want me to tell you the latest research on the article that tells you that COPD and smoking? Now, and sometimes we need to use statistics, so everything's a double-edged sword, all right? And you just got to keep thinking, why am I using it and is it working? And whenever it's not working, do something different. It's really... So it's really frightening, you know, you might say, gosh, you know, that last admission, you know, I realised that you were pretty scared. It's so frightening when you can't get your breath. Gee, it's frustrating when you think you're taking those medications, but they just don't seem to help your shortness of breath. And again, that might be a whole misperception that she thinks, I took my pill, my breathing's still, you know, people have totally unrealistic expectations of why they're taking their medication, or they're wondering why their preventer.
Or even how they work.
Totally.
Have they used it?
Oh, absolutely, yes. And don't.
YouTube of the lady.
The asthma.
The asthma.
Absolutely. That was standard. That was standard in our workshops of taking it. It was fantastic. And the other, I'd absolutely go and Google Bob Newhart, Stop It. It is hilarious, absolutely hilarious, and a fabulous reminder to all of us. So, sounds like you're having a rough time, like, what do you feel would help you the most at the moment? Try and ask that targeted, as opposed to how can I help you? It's just like, what do you think will help the most? Okay, communicate in a way that supports adherence. And this is the hard bit of, there are times when it's great to ask your clients things, but in things like COPD and in lots of complex medical things, there's no point in asking your patient because they don't know. They haven't done all of the training and they don't have your expertise. So a lot of the time, sometimes it's much faster to say, would you like me to just outline a couple of the key points I want you to take away about having this disease and the few top things that are the most effective? And people often go, oh, please, that'd be really good. Okay, so for COPD, yep, some of your lungs will be damaged. You're never going to get that back. But the good news is that if, in fact, you use your medications well and you actually train up the rest of your lungs, you can actually often manage this really well. And that's, again, ask yourself, can you explain why exercising helps? Because most people with short of breath, when you say, oh, let's go for a walk as the physio, and let's exercise, they go, dear, I've got COPD, I can't do that. Right? And of course they don't want to. They're going, I'm short of breath, you nincompoop. You know, I can't exercise. And so the analogy I use is that, you know, 40 years ago, Mrs. X, when you went up the stairs and puffed, were you worried you were going to die? No, of course not. Right. Well, it's the same now. Not all your shortness of breath is because of your lungs. You can still be short of breath just because you're unfit. And then you teach them how to gently exercise and you explain to them that it's really easy. If you overdo it, your techniques, everything, it will not work and you'll feel awful. You've got to be really slow and steady. So, they need a lot of information. So things that good above the line openers, just as a few. What do you think would help you the most? Do you believe that your medications will help? So it's again going for the belief. If she's saying, oh, that medication is, doesn't seem to be doing much. And you go, well, do you actually believe that if we've got the dose right, or what were you expecting as the change? And maybe that's the bit of information you haven't provided yet, is that you're not actually expecting it, that it changes their shortness of breath when they do something that increases their capacity, you're looking for a really long-term change. So they may not understand that. And, you can often offer a bit of information and say, pacing your activity, building your lung capacity, understanding when to worry will all help you manage your shortness of breath, other than taking your medications. And maybe the issue is the medications are doing as much as they can. Maybe we need to consider adding some other things to get a snowball effect. Would you like to know more about these? Here's a good one of an importance question without the word importance. How keen are you to actually explore other ways to reduce your shortness of breath other than the medication? Because how often, well, I can tell you how often it happens when they get to the physio or anybody else. What do you think the client says when you suggest they should do something else for their shortness of breath? What do you think the patient says? Sorry? Oh, well, that's why they're there, yes. But they say, no, I'm fine. I'm taking my medications. So there's a misperception that medication is enough. Well, gosh, who here isn't looking for the fastest, easiest cure? Isn't? Correct. We're all looking to make life easy. Yeah, and here's another tip, is you talk about the other things of using, and you'll have heard this, but it's using movement and food as treatment. Because as soon as you say, let's discuss lifestyle change, how motivated do you think people are? Oh, exactly. Nobody gets up in the morning and says, I think I'll set a goal around healthier lifestyle, other than some allied health professionals. But how keen are you is really another proxy for motivation and kind of readiness. So that comes to perhaps this table. You had an importance question, but without the word importance. What was your importance question?
Well, you wrote it down, Charles. So.
We've got three because medicine has the rule of three.
Oh, right.
All know that. So first one, how are you going to manage your smoking? How are you going to manage your smoking?
Okay, that's not an importance question.
Okay, we'll move quickly on to number two.
That's it. So that question is an excellent below the line to investigate strategies. How much do you feel you need to manage your smoking? So you had half of it there.
Next one, how pressing is it to manage your medications?
Yep. And we were talking about, often when you say it aloud, it's some things work better than others, but pressing was a really nice word, and thought that it worked better probably. How pressing is it for you to get a handle on pacing your activity? Kind of rolls, it fits a little bit better in my view, but
And the third one, how much do you think it matters to avoid infections and get vaccinated or have vaccinations?
Yeah. Okay. How much do you think it matters? So there's a whole lot of ways you can phrase it, and a lot of the time this language isn't as built in as how are you going to do it? Why aren't you doing it? Just that's it. Yeah.
Oh, sorry, that's the teenagers. Sorry.
Yeah, well, and the good news is all of these skills work on your teenagers and prevent you killing them. Mine are still alive, so.
It's news.
Yeah. So here's a few other examples. How critical do you think it is to take your medications as regularly or as prescribed? How keen are you to build up your physical activity? Or the other one with something like that, knowing, and often when you look at that question you go, yeah, 90% of people are going to go, nah. So often you need to reword it or think of it in another way. It's what benefit do you think you'd get if you increased your physical activity?
You could ask them if they had a dog.
But they will have, that's, a person with a dog will know that that's an option to do it. So if you're thinking that you need to give that sort of thing, that's you just politely telling them what to do.
Well, I was going to go around the other way.
Uh-huh.
And, you know, if the dog is important and the dog is,
Yep.
you know, part of that emotional support as well, it might be, you know, how important is it for you to, you know, make sure that the dog has an enjoyable life?
Yep.
So it's shifting that away.
Sure.
What would that look
Dog
like?
needs the
Yeah.
exercise.
No, that's right. And the other, that's where the question of what benefit might you get, or what would be the impact on the family if you were a bit more active, all of those, and they're just even more open. So yeah, but that's right, there's a lot of ways to do it.
Could you do it as a two-part question? Like I had originally written, how do you feel the medication is working?
Yep.
Prior to saying how critical do you think it is then to take it? Because
Sure.
I feel like it might mitigate some further questions about it.
Yeah. And herein lies, when you get to language, herein lies the massive problem of kind of trying to work it on something that's not real, and that you don't have a whole conversation and it's not aligned. So the gold standard for actually reviewing what happens in a consult is audio record it, and that's the purpose of the methodology. You can then map. Did I do that? Did I outline that? Did I ask and check about that? Or was there enough in the conversation that indicated, oh, they said this and this, which would indicate, oh no, they're ready enough, and so you went forward. Remember, you don't always need to, and I can absolutely tell you, if you do this well, this conversation well here, and start that off, you never need to ask about importance, because it becomes just a sharing of information, and the patient prioritises it. And you just go with that, and then you're off. That's why this structure makes life so much easier, because you don't have to play these games to drag people below the line of coming up with the solutions, because they see the benefit of it.
It would be better tailored to the patient and their intelligence.
Sorry?
The patient and their intelligence should be tailored the question according to the patient and their intelligence. And their
Yes, absolutely.
If I ask the patient, please, okay, how do you think the impact when you take the dog for a walk? If she's intelligent, well, I may get better.
Yeah.
Other one, she will say the dog will be fitter.
Yeah, exactly. Yeah.
How should we do that?
Yeah, absolutely. So everything is absolutely tailored. And this is a really nice phrase. Given everything else, or given what your situation now, How much do you think you need to pace your activity? Because you know how people go, oh, one day, or when this crisis is over, or, you know, they keep putting it off into the future. And a lot of the time it's, no, given life now, can you see, you know, it's where can you act now? And that's a totally different mindset. It puts people in a different mindset of what's possible, or because it really anchors them in reality. And obviously these questions are really good and are part of the RIC-focused decisional balance of asking about the benefits and consequences. Because if people don't know the benefits and consequences, well, that's why they're not motivated. So what might be the consequences? Now that is a little formal, you know, so that wouldn't work for everyone. If you didn't bother getting a bit fitter, what might happen, you know? And so it's really good to pose that question. So say, you know, we're all banging on about you taking medicine, but we keep wanting you to get fitter, don't we? Yes, you keep really talking about that, and I don't understand why, because I can't, because I'm short of breath. You go, yeah. Okay, so what do you think happens if you don't bother and you just let it go? What's going to happen in 12 months' time? And I can guarantee you, they cannot map that out because they do not know and they don't understand just general deconditioning and what happens to the lungs and all of those things that you can then go, oh, that's okay. Would you like me to just tell you what happens for people? A really good tip is when you're above the line, kind of talk more neutrally about other people as opposed to you, because it's less threatening. Then they're more willing to share information if it's a bit more neutral. What would be the benefits if you moved a bit more regularly? And you go for the physiological benefits and for the social, the emotional, get out in nature, you're less stressed, all of those things. And the impact not only on them and not just physical stuff, but the impact on others, of relationships, those things. That's what you're trying to draw out. Okay, so 3 simple steps to just getting more out of your own personal career in each day. We all intend to be person-centred, but not many of us actually know all of the ins and outs and the detail of actually how to do it and what that looks like. So by kind of either doing more, sometimes different courses, doesn't have to be health change courses, to really work out where are your strengths in the skills that you already have and where might there be gaps. That's where we've got to start, but you can see how critical it is that you've actually got to practice what to say in your context with all of the different types of patients you have. And there are some skills that you've got to practice, because it's really like learning German. And you know, you start off with a little bit of language, and then the more you practice, you will get more fluent. And you'll find your own style of what works with your clients. But over time, ideally, we've really got to actually address some of the significant roadblocks that are in the system that really often prevent us working like this, which are, we all know, considerable. So, but this methodology is a very well road-tested, proven way to deliver outcomes for your patients, better job satisfaction for you, and in fact all of those, not only the clinical outcomes and efficiencies, but often cost savings to the system of moving people more efficiently through our health system. So, the exciting news is we have a range of training and a range of implementation activities. I am launching a purely online mini course, which will just be a couple of hours, which will be focused mainly on kind of the RIC principle, similar types of things to what you've done tonight. And if you were wanting to find out anything more or have a conversation with me, by all means, get in touch. And more importantly, for today, I certainly do value your feedback. And so that's the link to the feedback form. And so that's really all I wanted to cover, but I'm very happy to certainly open it up for questions or, keep the discussion going a little bit more. But I'm also very cognizant that you are all busy people.